I am really excited to be here with you all this morning. This is a topic that is near and dear to my heart. Just to briefly introduce myself, I am a licensed clinical psychologist in the state of Virginia. I also am a certified mental performance consultant. My background is I have my master's in sport and performance psychology and went on to get my doctorate in clinical training, in part because kind of in my master's training recognized that the scope of practice and care was pretty limited to those mental skills and wanting to be able to, wholly meet people where they were at. Also recognizing that kind of in some of the work I was doing with individuals, there was a lot of intersection in athletics between eating and body image concerns, performance issues, and wanting to be able to, again, to just wholly meet people where they are. I've worked in a variety of different settings. Currently, I'm an embedded psychologist in a university athletic department, providing clinical and performance, individual support, as well as, team sessions and consultations. I've also worked at an outpatient clinic that was solely focused on outpatient eating disorder care. And in my graduate training, worked at a higher level of care residential facility for eating disorders in Denver. And while I was there, they are one of the few treatment centers kind of in the nation that offer kind of specific athlete track for treatment, recognizing that can be an important identity concern, cultural concern. There's unique challenges in kind of navigating the world as a student athlete or an elite athlete who's getting paid, and challenges to recovery. The focus of this training will be on the assessment piece, as well as then kind of the importance of doing that assessment to make appropriate treatment referral and considerations. At the very beginning, we'll do a very brief overview of DSM diagnostic criteria. We're not going to go in depth. Very much just acknowledging that there is a section in the DSM. These are common kind of diagnoses that you might see. Also recognizing that kind of in utilizing insurance, the need for that diagnostic code. But before we begin, I think it's really important to recognize that everyone has their own relationship with their body and eating and food, and that is informed by our own experiences, both from family, society, and that there are pervasive unhealthy norms. We are entrenched in a society of diet culture, of wellness that can be very much kind of entrenched in privilege and high SES, and just recognizing that there are very unhealthy norms and that we all kind of are in that water. And so just with any other, as you would with any other presenting concern, recognizing, that we're not walking into the room with a blank slate. We're coming in with our own lived experiences, our own biases, our own assumptions and perspectives in the area of eating and food and culture, and that just to be aware. And part of my hope in this presentation is kind of also increasing awareness of how your own lived experience may help facilitate or at times may help interfere. And there's no shame in that. It's more kind of catching that awareness, giving ourselves self-compassion, and then being able to be present and do the proper assessment, and just being aware of, yeah, how are we walking into the room? And so to begin, this will be kind of our first Mentimeter. I'm curious just to hear from you all, as a clinician, what you feel most challenged or concerned by when thinking about an individual that presents with eating or body image concerns. Yeah, so I'm seeing both from kind of people responding to the Mentimeter, safety, the physical health and safety, wanting to have the correct tools to help them, cultural considerations, navigating the cause of that eating disorder behavior, if it's purging, restricting, binging, creating a space to overcome shame, how to keep my own struggles with my relationship with food and my body in check as I try to help the client. Absolutely, that can be really challenging. Medical safety, co-occurring issues, when to get health professionals involved, limited coping skills, which can be really hard then in shifting that behavior. How to promote positive body image when clients feel shame and don't want to talk about it. How long it's existed and what psychosomatic symptoms and behaviors. Death of client, death and safety, medical complications and implications. I think I always like to start with this question, in part just to recognize that there's a lot of shared concerns around physical health and safety, treatment, knowing how to prioritize what needs to happen, especially at an outpatient level where you might feel perhaps more isolated. I know I've worked at a variety of settings where, at a residential treatment center, there's those concerns, and it in some ways is easier to leave work at work because there's physicians, nurses, psychiatrists, they're in group, they're watched, they'll be okay. Where I know when I worked at an outpatient clinic, there was a lot more concern around, you know, connecting them to other providers who were, had that specialty, safety. I, had to refer a couple individuals from session to the ER due to concerns around the frequency of purging and just really wanting to get their electrolytes checked. And just recognizing that, yes, there's real physical and safety concerns. Eating disorders, have one of the highest mortality rates of all mental health concerns and comes with significant, physical and medical complications. So thank you all for sharing. I have to remember that my arrows don't work on my and so kind of going off of that, if you've had this experience or as you're thinking about it now, how do you balance your own relationship with your body and beliefs around eating and bodies when wearing your provider hat? I may have worded that question wrong, but wanting to know how you balance your own relationship with your body and food, and then coming into the room and then having to focus on a client wearing your provider hat and being present for them. Yeah, the importance of not assuming what works for one person works for others. Seeking therapy, intentional and appropriate self-disclosure, focusing on tools and research around body image and self-compassion. I think self-compassion can be a great approach for both our clients, but also for ourselves. Normalizing different struggles. Sounds like just the intentionality of recognizing that what is our stuff and leaving it out of the room as best as we can. Utilizing clinical supervision, consultation. Yes, considering the cultural aspects and figuring out what messages the client has internalized. Recognizing that we all are carrying stories about our bodies. Yeah, just recognizing the influence of culture, and that can be our own family of origin culture, our larger community culture, societal messages and culture, and that sometimes that can be protective, and other times that might be, reinforcing more negative, harmful messages and stories that can be internalized by our clients and by ourselves. So again, I really appreciate you all kind of sharing in this way. Again, just recognizing that there's lots of different ways to kind of balance that challenge if that's something that you have experienced in the past. Let's see. So again, I just want to do a very brief overview of kind of the feeding and eating disorder section kind of in the DSM, recognizing that in having to utilize insurance, this is something, to be aware of. I'm not going to go over specifics, but wanting to just highlight a couple different pieces. ARFID, I'll just name that this presentation around assessment is more geared toward anorexia nervosa, bulimia nervosa, binge eating, OSFED. And ARFID, I'll share anecdotally, has increased on my caseload in college students and, has, I think, kind of research, I know at least in the UK, has suggested that in the last 5 or 6 years, there's an increase in prevalence. I think some of that could be due to just increased awareness, as well as increased awareness just about ARFID often co-occurring with a neurodivergent diagnosis. It's often characterized by a sensory aversion to food or a fear of consequences related to eating, if that's a fear of vomiting, a fear of choking, and can present as just almost like a lack of interest in food. Treatment, there's going to be overlap between kind of treatment goals and exposure. And it's going to look different because our people who are struggling primarily with ARFID don't typically have body image concerns. So their eating behavior is not tied to, a desire to control body shape, weight, or size. There's not a presence of disordered body image. There may be, malnutrition or nutritional concerns due to their very restrictive kind of food intake and what they're eating, but that it again can present differently and just is not going to be the primary focus of our assessment today, but recognizing that if someone's coming in with a history of very picky eating, sensory aversion, kind of safe foods that they're eating. So I'm currently working with someone who has a desire to increase variety, and it's impacting kind of social settings, connecting with others, fueling for her sport, because her safe food is, chicken tenders and barbecue sauce. And so while that can be a great meal, if that's the primary thing that you're eating, you can kind of see there might be some nutritional deficiencies, which might increase risk of injury just from underfueling, as well as imagine kind of navigating social settings or wanting to travel or experience kind of other things that can be very restrictive. There can be a lot of embarrassment or shame. Anorexia nervosa, bulimia nervosa, and binge eating disorder, as well as that otherwise specified feeding or eating disorders, are going to be the most commonly used when thinking about, in some ways, like what people think about when they think about eating disorders in terms of that restricting, binging, purging behavior. That's going to be present under these three. I think it's really important to name that there is very common crossover throughout the course of an illness. And so what I mean by that is someone may, primarily present with anorexia nervosa restricting subtype, but over the course of the illness, may present more with the subtype of binge purging, may develop binge eating disorder and no longer engage in restricting or purging. And just recognizing then that when doing your assessment, getting that history, but also the diagnosis is more reflective of the current behavior. OSFED replaced eating disorder not otherwise specified from the DSM-4. And this is probably in some ways the most commonly used diagnosis, recognizing that there can be in some ways, boxes that have to be fit under the other ones of frequency, duration, sometimes, weight or percentage of weight. The otherwise specified really captures that if someone is engaging in purging, there's a separate purging disorder subtype that really kind of highlights that a behavior can be problematic, impacting quality of life, but might not meet the threshold of bulimia nervosa if they're not engaging in the binging part of the purging or the frequency of the purging. So otherwise specified also includes the subtypes of purging, as well as atypical anorexia. And I'll just name that atypical anorexia, in some ways, the more typical anorexia, because recent statistics from 2024 show that less than 6% of individuals with a diagnosed eating disorder are considered medically underweight. And so that the anorexia nervosa diagnosis, many people can be experiencing kind of that restriction, can be at an unhealthy weight for their body type, can be experiencing medical complications, but may not be considered medically underweight, which I think also just, indicates the kind of problematic use of BMI for kind of categorizing the different subtypes of that restricting subtype or severity. The other piece here, just the unspecified feeding or eating disorder, that can be often used when there's information or recognition that eating is impacting quality of life. There's some disordered eating present, but there's not enough information to make another diagnosis. This can be commonly used kind of in triage settings, emergency room settings, or if a clinician decides for a specific reason not to diagnose with something else. The other thing I'll just name, this is not a DSM diagnosis, and I don't know if it will be in the next edition. But given the kind of shape-shifting of diet culture and focus on wellness, there's a term called orthorexia, where someone might have the intention of eating more healthy, recognizing that everybody has a definition of that. But there can be a kind of obsessive compulsive nature to healthy or, quote unquote, clean eating that often then kind of snowballs into very restrictive eating. So this could be, beliefs around certain food groups. This could be beliefs around the way that food is made or processed, but then leads to, can lead to nutritional deficiencies, but also like impact one's ability to be present and fully engaged in life. So just significant kind of ruminations around food impact, relationships, that social connection, impacts quality of life. And so, at this point, that would be, considered, and the OSFED would be the diagnosis, but just recognizing that, again, that is clinically showing up more and more where people are coming in with, concern around healthy or clean eating, a lot of intersection between maybe the fitness culture and relationship with self, body, and food, and can, develop into disordered eating, problematic eating that impacts quality of life. Just wanting to highlight a couple other diagnostic considerations. Body dysmorphic disorder is under the obsessive compulsive and related disorders in the DSM-5. This can coexist with an eating disorder, but it is not the same as the distorted body image around kind of weight, body shape, size, body fat that is most often seen in kind of anorexia nervosa, bulimia nervosa, binge eating, OSFED, and can be often seen. This could be, I've worked with someone who, had body dysmorphic disorder around their left side of their face and being very concerned about the symmetry of their face, and then engaging in repetitive kind of body checking behavior around that. Again, that can co-occur with an eating disorder, but is just wanting to highlight that that is different than the distorted body image that is often present with an eating disorder. Also wanting to recognize that things don't happen in a vacuum. This is one of the reasons that I wanted to go on to get my clinical training after my master's, because things don't happen in a vacuum. So eating, feeding disorders are often comorbid with other mental health concerns. And those other mental health concerns are typically why someone is maybe presenting. If that's anxiety, depression, PTSD, OCD, and it can be hard then, kind of given what's coming into the room, to even think about assessing one's relationship with eating or their body. But also just wanting to name that if there's not an assessment done and there is some disordered eating or eating disorder present, that continued behavior or maladaptive coping can interfere then with the treatment of the presenting concerns of why that individual might be coming in. And so the clearer the picture that we can get on kind of everything that's happening and what is driving the behavior, the more effective treatment we can provide. And so this also just recognizing that people can experience an increase in appetite, overeating or reduced appetite, undereating, lack of motivation to eat in the presence of a depressive episode. Individuals with anxiety, especially who experience high physical symptoms of anxiety, can experience reduced appetite, may experience weight loss. And that, again, part of that assessment piece is really figuring out then what is driving the behavior. Are these eating concerns limited to kind of those episodes of depressive or heightened anxiety? And is the treatment then going to be targeted on that? The other piece is, if someone is, with the exception of ARFID, if someone is having, difficulty with appetite, eating, and not experiencing body image controls, not, attempting to control their weight and shape, often then their eating behavior is probably tied to something else. I kind of already mentioned, some of the maybe problems with the DSM-5, but also recognizing that this is the system that we're in, and in providing healthcare for individuals who are insured, we have to use it. But just, I think with eating disorders, especially, it can be common that individuals often don't feel sick enough or worthy of treatment, and that the best time to seek help is if, quality of life is being impacted. This can be hard when working with insurance and then justifying kind of medical necessity, but also just recognizing that there's a lot of misconceptions around eating disorders and systemic injustices to be aware of that impact then both access to treatment and getting effective treatment. And so there's, a common misconception or stereotype that eating disorders are a white woman, issue, often middle class issue. And not only is this false, eating disorders don't discriminate, but it's also problematic because if we're operating under that assumption, there's gaps in research on the prevalence of eating disorders in Black, Hispanic, Native populations, in part because they're often not even asked what their relationship is like with eating or their body. And so if someone isn't asked, it's really hard to then get them connected to the right treatment resources. And so these individuals are half as likely to be diagnosed, receive treatment, or even be asked by a provider. Also recognizing that disparities exist kind of between insurance, type, and race. And in our current healthcare system, those on government subsidized health insurance often have fewer options for medical treatment. And this is also then a barrier to accessing appropriate care. There's also been, some research done on a lot of the eating disorder treatment that is available, thinking about kind of a higher level of cares. I think there's been a shift in recent, years, in the last 10 years, of being more kind of culturally aware, culturally sensitive to everybody's, lived experiences and being more inclusive, but recognizing that misconception of this being a white woman's issue has also then shown up in treatment. And so some individuals who are then accessing treatment might not feel like their lived experience, their culture, their identities that there's space for them. It's that this is an ongoing systemic issue. And I think when I think about then my role as a clinician, an N of one person, really wanting to create a space for an individual with that assessment where we can talk about their experience, the stories and messages that they have learned and heard about their body, and either in ways that are helpful, what has been helpful from their, family background, their culture, and ways that even maybe then society has not been helpful and interfered with the development of sense of self. This is often an image that I will share with individuals that I work with. Again, just wanting to highlight that dieting is a predictor of disordered eating behavior, and disordered eating behavior, you can imagine like a spectrum, is often a very slippery slope then to the development of a clinical eating disorder, which, as people shared at the beginning, there's concerns then around kind of the physical medical concerns and just the seriousness of that. So again, wanting to create a space where we're assessing to be able to intervene kind of earlier on in that spectrum. It's not uncommon for individuals to come in, at least kind of in my practice experience, very concerned and wanting to stop binging. They feel out of control, especially in the evening. And, they used to be so quote unquote good. And now they're feeling out of control with food. And recognizing that this can feel very counterintuitive to the individual sitting with me and is not what they want to hear. But to reduce the binging or feeling out of control with eating, we actually have to move up earlier in that cycle to reduce the restriction. And restriction can take on many forms, right? So it can be skipped meals, but it can also be, eating every few hours, but not eating enough for that individual's needs. It can be mental restriction. So the idea of having these, food rules, I will only eat certain types of foods, or I will avoid carbs. It can really, I will avoid fruit. There's lots of ways that this can come up. Mentally restricting increases, hyper focus on food, and often then increases those cravings, which can lead, to the binging behavior. And then there's also the restriction of delaying eating. So if someone goes, 4, 5, 6, 7 hours without food, our brain's number one job is to keep us alive and survive. And a part of doing that is we need calories. And so if we go too long without eating, our brain is going to override any mental food rules that we have, and really access the quickest, most convenient calories that are easily digestible is often food that can be considered off limits, or people may engage in with binging or feel like it's a treat. So easily processed, digestible carbs for quick energy. And so often a visual that I will share with clients, and asking kind of what they have experienced with this. This can often be a way to even start having a conversation around what food rules might be present, or how they might be restricting, even if it's unintentionally, that's leading to that binging at night. Recognizing that I work with a lot of athletes, so their caloric needs are going to be different than the general population. So even recognizing, like, comparing one's plate to another person's plate is just not helpful for lots of reasons. One being that the caloric needs are just different. So it can look like you're eating enough, but it might not be enough for your activity level. And so that unintentional restriction can also then cause this cycle here. All right, so when thinking about assessment considerations, the goal is really to just get an overview of an individual's relationship with eating food in their body. And then kind of given that information, there might be additional questions to ask to get a clearer picture of how much this is impacting one's day-to-day life. Really thinking about, how long kind of symptoms, thoughts, behaviors have been occurring, as well as level of insight that an individual may have. I saw it noted earlier, kind of with one of the concerns, is that it's not uncommon for someone to come in and other people in their life or the clinician is very concerned about their eating behavior, health and safety, but that individual does not share that concern. And so getting a sense of kind of level of insight and motivation for treatment. And that, doing a thorough assessment can also then help determine kind of the appropriate level of treatment, if that's outpatient or a higher level of care. I think just also recognizing that since COVID, hospital admissions for adolescents for eating disorders has more than doubled since the pandemic. And the stats I'm sharing today are coming from the Alliance for Eating Disorders 2024 report. So just that recognizing that there has been an increase in eating disorder behavior. And unfortunately, and this was, named earlier as a concern around that health, safety, and mortality rate, that every year a little more than 10,000 individuals die as a direct result from an eating disorder. And I don't say that to scare you. I say that more to underscore the importance of creating a space where we're having conversations about what that relationship looks like. I think it can be really common to um, focus on just what the client is coming in with, especially like just coming from like a person-centered model of like wanting to really validate and hear the client's concerns and just recognizing the importance of gathering information, even if that's not what the person is coming in with. And so just to be aware of common physical and cognitive symptoms. This is not a comprehensive list, but wanting to highlight a few different kind of things here. Under the physical symptoms, you'll see some of those are asterisked, and those are often physical symptoms that will present first. So it's really common for someone who's engaging in disordered eating behavior to experience a loss of hunger and satiety cues, which for that individual can be a relief. It can be really easy then to go long periods without eating. It can also make it easy in some ways to eat just a little and feel very full. For other people, it can kind of have the opposite impact. I will often have people come in and say, well, I'm only eating when I'm hungry and I stop when I'm full. But if someone's been engaged in behavior for a period of time and they no longer have those cues, that is no longer considered intuitive eating. And if someone comes in with a disordered eating, relationship or eating disorder, and their long-term goal is intuitive eating, I will always name that is a long-term goal, but in the short term, eating is going to have to be much more regulated, in some ways robotic. There might be eating, with alarms on your phone when you're not hungry to help kind of turn those hunger and satiety cues back on. Dizziness can be, a sign of orthostatic hypotension. So if they stand up too quickly and feel that dizziness and lightheaded, that can be an indicator of kind of developing cardiac problems. Headaches can be common as a result of underfueling and fatigue. So, as I mentioned earlier, calories are energy. There's some research, done on individuals in comas who need at least 1,400 calories so their organs are functioning. And so recognizing that if someone is restricting or engaged in a restricting binging kind of behavior, they're often not going to be getting the energy that they need at regular increments, and so feeling very fatigued. A couple other ones that I just wanted to highlight in terms of physical symptoms that clients might come in naming. It's really common with restricting, binging, purging to have GI distress. So someone might name feeling bloated often, constipated, or nausea. Bloating can be, for some individuals, a trigger for, poor body image or a trigger for this thought of I need to eat less. When the reality is similar to the loss of hunger and satiety cues, if someone is not eating at regular intervals, is not eating enough for their body, bloating, GI distress, you can almost imagine a propeller on a boat. So when it's running, things are going well, it's going at like the normal interval. When someone's engaged in disordered eating behavior, their digestive system is going to slowly shut down because it doesn't need to be operating. And if we're trying to conserve energy, that's going to be something that goes. So you can imagine the propellers are, slowing down, and that is going to cause the bloating, constipation, and GI distress as things are moving more slowly through those systems. And that is a result of the eating disorder behavior, not from eating too much. Recognizing that for some individuals that might, in a different context, different presenting concerns, bloating might have a different indicator, but just wanting to name for people who are struggling with eating disordered behavior, bloating and GI distress is often a result of that restriction, binging, or purging, dysregulated eating. When I'm assessing, I'll ask, about an individual when their last menstrual cycle was. For males, there's been research that restricting or underfueling, that if there's a loss of morning erections, that can be an indicator that, to really look at kind of that eating behavior and making sure that they are fueling for their needs. I will also just name, I recognize that I'm kind of using kind of fueling, underfueling, restricting, and different kind of words. And just working kind of within athletics, I will often use fueling and fueling enough for one's activity, fueling enough for one's body's needs, rather than, or kind of interchangeably with kind of restriction binging. The other thing that I wanted to highlight here under the dehydration and electrolyte imbalance, this is when a referral to a primary care, or depending on what is available at an urgent care, just some lab work, like a complete blood panel to look at electrolyte imbalance. It's really common with purging behavior for someone to experience just an electrolyte imbalance, specifically around potassium, sodium, chloride, and bicarbonate. So getting a picture of how their purging behavior is impacting their medical stability. And so if someone comes in reporting purging behavior, this is often the first thing that I'll refer to, of getting, a comprehensive blood panel to really look at what's happening. And if, depending on kind of what that blood work comes back and says, it might be that if it is, they need to go to the ER to get stabilized immediately. If this is, information, evidence for further conversation around kind of an increase in care, and that is just really important. I'll share that, validating kind of the concerns that were named earlier, purging is definitely something that that is, like, I sometimes feel like we're playing Russian roulette, because you just never know what's going to happen, or what time what time a purging episode might result in a cardiac event. And so just naming that is a concern that I also have when working with purging, and have found that kind of getting someone connected to a physician, primary care, urgent care, to do some of that blood work can be helpful in kind of getting a clearer picture, can also be helpful in getting buy-in from an individual of why this is such an important behavior to address. The other thing that I'll just name is for people who are experiencing more of the binge purging behavior, if that's either kind of with the anorexia binge purge subtype or bulimia nervosa, they might have the provider that first might express concern is their dentist. If there's enamel loss or teeth erosion. You might also, as the clinician, there's what's called the Russell sign, where someone might present with abrasions or lacerations on the back of their knuckles from that self-induced vomiting. And so that can be something to kind of look out for as well if there's concern. I think the other thing I'll name is that long-term, there can be really significant health consequences. If that's, osteopenia, osteoporosis, or bone stress injuries, or infertility, difficulties or challenges. And I have found that, depending on the individual's age, depending on the individual's motivation or desire kind of for what their life looks like, that sometimes those long-term health consequences can be really helpful in kind of getting some initial buy-in or motivation on making some behavior shifts. And sometimes, depending on the age, it can feel like, oh, that's like a long ways off. I won't be struggling with that at this point, or that won't impact me. And so there's, I think, importance in kind of educating an individual on, if you continue to kind of engage in these behaviors, this could happen. Sometimes I have found that to be helpful. Sometimes it's, my future self will kind of deal with that on a future day. And so wanting to name that. And if you're meeting with someone who is reporting, a history of increased fractures in the last year or other bone stress injuries, that can also be an indicator for you to, do a further assessment on eating, or referral to a physician, because those stress injuries, fractures might be a result of underfueling and not poor luck or biomechanics from sport or, just an unlucky fall. Common cognitive symptoms that are going to initially present are going to be someone's, a reduced ability to focus, decreased memory. Things are just going to feel a little foggy, as well as reduced processing speed and slowed speech. So this can sometimes look like having a harder time kind of recalling things between sessions. This can be having a harder time kind of staying on task with you or being present with you in session. Slowed speech is definitely an indicator of pretty severe restriction and a need for higher level of care. And the rumination on food can present in session in lots of different ways. So they are going to be hyper-focused on food, when their next meal is. They also might love looking at menus. They might love, preparing foods for other people. They might ask you like what you had for lunch that day or what you're doing for dinner, or, if you've been to this new restaurant and what you got, but really wanting to spend a lot of time talking about food, in some ways even being around food, but just not necessarily eating it, or eating it only kind of in secret on their own, but not in social settings. So the next few slides are just example questions to start asking at intake or assessment. So some of these are just example questions to really kind of get at assessing behavior and thought process. I think and it looks like you all are asking about appetite. So really getting a picture, like what a typical day of eating looks like. And I will often then follow up with like, what does, recognizing I'm not a dietitian or nutritionist, but wanting to get a sense of how often someone is eating. And if they feel like they're eating enough to fuel their activity. I will often ask if someone tracks their food intake. Are they using an app? Are they kind of counting macros, if it's carbs, proteins, calories, whatever it might be? If someone, pays a lot of attention to the timing of their meals, do they feel the need to prepare their own foods? Do they only go out for food? Are there patterns around that? Are they avoiding certain settings because of their relationship with eating, or avoiding social interactions because of their relationship with eating? Do they only eat alone? Another question that I'll often ask is if someone has ever delayed eating despite feeling hungry. And so, some people might chew gum to kind of keep their mouth busy, drink more water, or drink kind of carbonated beverages, if it's sparkling water, Diet Coke, to feel full. And that can be a behavior that can be considered normal depending on what was modeled for somebody growing up, or kind of what messages have been internalized. And so even I think asking the question can help start creating a space of, oh, like just because I'm doing this, like other people might not be doing this. This might actually be related to something else. A question I'll always ask everyone that I meet with, is if they've ever purged after eating. And I will often explain purging. So, if it's that self-induced vomiting, if it's laxative or diuretic use, or exercise to kind of make up for calories eaten. And then wanting to get a picture of if someone is operating kind of on a day-to-day with having certain food rules. And I think this can be a really interesting conversation with individuals because it's not uncommon for people to have food rules because of either the society that we live in or family messages or values around food. And so getting kind of a picture of what messages have been internalized by that individual. So for example, growing up, I grew up in a very active household and ran track as a kind of pre-workout snack. My mom always had like a bagel available. And you can like bagels can be considered, especially in the early 90s, like that is, goes against the grain of Atkins and kind of the carb fear mongering that was happening. But she saw bagels as a good kind of pre-workout fuel, but refused to buy Pop-Tarts. And it wasn't until I was in college when I realized that actually I preferred Pop-Tarts as a kind of workout fueling because it was more easily digestible and didn't make my stomach hurt. And so recognizing that I didn't necessarily think of it as a food rule, but I just never had Pop-Tarts until my roommate got them because Pop-Tarts weren't allowed in my house. And having a conversation about kind of what you've brought from family or messages you've learned or what is considered okay or appropriate to eat at certain times can be illuminating. And also just increasing insight for an individual about like, oh, okay, like there are other ways to go about this. That might not happen right at that first session, but just creating a space where what foods were, what were dinners like growing up? Did you have to prepare your own food? Was there food scarcity? Did you have food available to you? Did you grow up, where you have had experiences where your hunger and satiety cues weren't on because there wasn't food easily available or prepared? What were messages around kind of food available or not available in the house? And just being really open about kind of hearing more from that individual's lived experience and how that's impacting kind of current behavior, current relationship with food. When assessing exercise, again, I just like to start with a really broad question, and depending on how the individual engages with that, what they share or don't share, kind of even maybe what their nonverbal body language is, kind of assessing further. So really wanting to get a picture of what somebody's relationship with physical activity looks like and messages that they've received about physical activity. Is this something that uh, has been used as kind of punishment or shaming behavior? Are there movements that they do enjoy? If someone is maybe more engaged in obsessive rumination around exercise, wanting to also get a sense of, is someone tracking their activity? Um, if if an activity counts if it's not tracked? Are there times where they just are enjoying kind of how movement feels? And another one, kind of both with eating and exercise, is also getting a picture of how does one feel when they're not able to engage in the physical activity that maybe they had planned that day? How does one feel on an unplanned rest day? This can be especially present kind of within athletics. And then also kind of with those food rules, how does one feel when they're not able to follow those food rules? Or how does one feel when they've picked out what they're going to get at dinner at the restaurant that night with friends, and then the menu has shifted and what they were going to pick is no longer available? Basically, when things don't go as planned, as they had wanted in both of these areas, how does that leave them feeling? It's not uncommon for there to be kind of increased anxiety, increased kind of feelings of just being on edge, restlessness, guilt, shame, and just a desire in some ways to isolate and kind of then engage in the behavior to feel better. Which, in the short term can alleviate that anxiety or distress, but in the long term, not then having the confidence that, oh, I don't actually have to follow this, or it's okay. Like I'm still okay and confident if this doesn't go as planned. And that can be then part of treatment in some ways, kind of that kind of exposure hierarchy. The other question I like to ask around exercise is just getting a picture of, I think for a lot of people, there can be this idea that like exercise has to happen in a gym, and really wanting to get a picture of like just what an individual's relationship with movement is and how active they are throughout their day. They might have a very active job. They might have to walk a lot on their job or lift really heavy. And so wanting to, again, create a space where, yes, someone might be going to the gym for, a few days a week to exercise, but there's also other activities and wanting to get a sense of how much headspace is being taken up by physical activity, and how much someone is doing kind of on a day-to-day. So again, these are just some example questions for body image. Again, starting really open, wanting to hear just what their relationship is like with their body and how that has changed over time. Sometimes I'll share, that body image is this multidimensional thing. So it's not it's very common for people to feel differently about their body in different settings. And so asking then, are there times where you feel more confident, in different settings? If it's at home with your family, if it's out kind of with your, chosen family, close circle of friends, if it's in your performance settings or work, certain outfits, when do you feel confident and when do you feel less confident? I think it's really important, an assessment, and then this can also be a part of treatment, of really creating a space to talk about what is the narrative around their body. What is the narrative that they have internalized about their body? And is that different than family messages? Or has that been reinforced by societal messages? And so I think a great resource around kind of just the intersection of culture and body is Sonia Renee Taylor's The Body is Not an Apology. And she talks about, the reality of the body hierarchy in our society that is entrenched in white supremacy. And so recognizing that certain bodies in our culture are inherently more worthy and then treated as such. And so recognizing that I live in a body where I inherently have more privilege. White, cis, I am in what is considered a smaller body or thin ideal. And so being aware that that my body may have stimulus value or comes into the room, and being cognizant of acknowledging that, when it's appropriate, and having a conversation about how that might impact then kind of the conversation or just what it's like then to talk to somebody in my body, and messages that someone might have received in their body. I also think it's important, kind of going back to kind of checking kind of assumptions and biases. You might be in a similar body, and have received very different messages about your body growing up. And so I recently worked with somebody who, so I'll also share, I'm quite tall, and I received different messages about that growing up. And I worked with someone who, identifies as a woman who is taller than me, and she, because of her sport, received a lot of messages that she actually wasn't tall enough for her position, and the impact kind of on the developing kind of view of self-worthiness, what her body was worth, and how that negatively impacted her and relationship with body and food. And so recognizing, again, that you can come in with overlapping some shared identities, overlapping, if it's invisible or visible identities. And there might be some common shared experiences where you can intentionally and appropriately self-disclose. And there might be times where there's overlapping visible or invisible identities, and recognizing that people are going to have that different lived experience, different messages received. I think it's really important to also just assess like how much of one's headspace is taken up by thoughts of eating, exercise, body image, view of self, a sense of kind of that worthiness or worthlessness that someone might feel in their body, and how much does that impact someone's day-to-day. Getting a picture of how their physical activity or how movement affects one's body image. So it's not uncommon for someone to feel like they have to engage in some type of movement to quote unquote earn food, or be able to wear something for an occasion. And again, just having a conversation about how often that's happening or how that might be affecting one's body image. Or also recognizing that someone might be avoiding exercise or movement because of how they feel in their body and because of messages received around their body or body, how worthy their body is to be moving in certain settings. And I think just validating the impact of that, and naming that. I think assessing body checking behavior is really important. Again, I think part of this just comes from like a education piece of someone might be doing things that they don't even realize are like a separate behavior from them, that this can be a part of, a mental health concern, and that it doesn't have to be this way, and getting a clear picture of what's happening and how that's manifesting and how they're experiencing it can be kind of a helpful foundation to then start exploring decreasing those behaviors. And so common body checking behaviors can be weighing themselves, measuring themselves, taking progress photos, or spending kind of an excessive amount of time in front of mirrors and checking oneself, body pinching, or measuring body fat. Individuals can also engage in body avoidance. So I've worked with individuals who have covered all their mirrors in their homes, who have a hard time showering and being with their body, and may present in more, larger baggy clothes to hide their body. And so recognizing that, again, like most things, things can occur kind of on a spectrum and can cause distress, or the engagement and the behavior can in the moment avoid distress, but in the long term kind of increase distress and can continue to interfere with kind of the day-to-day functioning. I think it's really important when meeting with an individual who is presenting with body image concerns, who may name, fear of changing body shape, size, weight gain, not to assure a client that you quote unquote won't make them fat. This both reinforces kind of that thin ideal is very fat phobic, but also reinforces the fear of gaining weight, that somehow if someone has to gain weight or weight restore, that is inherently negative. And so I think it can be common, right? We want to offer reassurance, validation to a client's concerns, and just being really aware that that is an unhelpful and fat phobic validation and reassurance to offer. Because the reality is, like I as an individual, don't know what where somebody's body needs to be. And it might be different than what the client desires. And then part of the work is kind of that distress tolerance, increasing body acceptance, and self-compassion. So I'm going to just start going through some of these questions. Molly asked if I would advise against weighing daily or would that create further issues? If someone's coming in and weighing daily or multiple times a day, I think working toward decreasing that can be really helpful. I think providing psychoeducation that weight fluctuates pretty significantly kind of throughout one's day, depending on hydration, if it's an individual who has a menstrual cycle, kind of time in that cycle, how much salt or sodium has been eaten. And so kind of going over factors that can influence just weight fluctuation that have nothing to do with actual weight change. I often refer to the number on the scale as it doesn't have a lot of information about somebody's health. It is a relationship with that individual's relationship with gravity, and that there are other kind of vitals that are more important that are going to be indicative of health. If that's somebody's blood pressure, resting heart rate, blood work, energy, ability to focus. And I recognize that this can sometimes be hard because you might be meeting with an individual that has experienced a lot of stigma, weight stigma, kind of interacting with the healthcare system. And so I just name that if I can be a provider who creates a space where health is, can be at every size and there are other vitals to kind of track, as well as then just kind of creating, if someone is weighing daily, even taking out kind of the kind of circle of anxiety of the weighing of daily is going to decrease anxiety, maybe depending on kind of what happens for a little bit, but is going to further kind of that compulsive behavior. And if that, depending on what happens kind of at that daily weigh-in, if that's then impacting eating behavior or impacting mood or how one feels in their body, what would it be like to experiment, if it's just kind of decreasing to every other day at first, to then once a week, to then, getting rid of the scale completely. I think daily weighing can be really problematic. And just also, even from someone who has, like, if an individual doesn't have any eating disorder history, isn't necessarily like a necessary behavior to be engaging in. That there's just other kind of health vitals that are just going to provide a whole lot more information about that person's health and medical status. I think that bodybuilding and figure competitions can be a very tricky environment for someone in recovery. I also think it can be a place where, not that there aren't people who engage in a healthy way, or engage kind of just for the sport and then are okay kind of turning off and being in the off season. But I think can be a culture that's pretty entrenched with disordered eating behavior and can make recovery or treatment difficult, because what's normal can be actually a very unhealthy behavior. There is often, yes, comorbidity with trauma. Eating disorder behavior can be, an initial way that someone is coping with a trauma, if that's establishing a sense of physical, emotional, or physiological safety in their body. I think I don't have like the research or recent statistics or numbers, but recognizing that eating disorders can be often comorbid with substance abuse, but can also be then another avenue of engaging in like an addictive behavior if someone is managing kind of the feeling of being sober and restricting, binging, purging. That can be a way to numb. So I definitely think there's definitely crossover with those addictions or comorbidity. I think even thinking about, I'm always curious for people who may then who get into bodybuilding or any endurance sport, recognizing that there is an increased risk in developing eating disorders. And there's been some research done on almost like people selecting into, different activities that may reinforce unintentionally, intentionally disordered eating. I also think recognizing that just certain, I mentioned that kind of the harm in the kind of misconception that eating disorders are a quote unquote white woman's issue, that, there's a lack of research to really indicate the prevalence in, Black, Hispanic, Native populations. And it is like there is a prevalence. I think it's not talked about as much, in part because it's not assessed or seen as from providers, if that's in the healthcare system or otherwise, as sometimes something to be assessed. Also recognizing that individuals who identify as part of the LGBTQIA, non-binary, trans individuals can experience there's an increased risk in developing eating disorder or body image concerns. And I think just really like recognizing that, if it's, and I think there can be a crossover in some ways between kind of the substance use or really any behavior. If it's substance use, any maladaptive coping behavior, recognizing and having empathy that there's a reason that someone is engaging in that. So if it's restricting, binging, purging, that they're like that behavior has served a function and might actually be like how that person has survived up until the point that they are sitting with you, and honoring that, and acknowledging that this has been something in some ways that's been helpful for you, and it is also harming you and impacting if it's relationships, ability to keep a job, ability to be, present in their families' lives, however it may be. Kind of just recognizing the duality that sometimes it can be hard to let go of a behavior that for someone has been so self-protective, and in some ways there for them when maybe other people who were supposed to be protecting them or you would think would be advocating for them have disappointed them. And so I have found, and I'll just name that I operate from like a interpersonal process kind of attachment framework, but really kind of wanting to honor like how has this served you, has been helpful in getting some buy-in of how do we start thinking about shifting this behavior. I think it can be hard when, as the clinician, you can see that there's problematic behaviors and that the client does not see that. So there have been times where I've named like, well, I have concern about like what you're naming is that there's a lot of headspace being taken up. You're avoiding certain things. You're not able to engage in what you need to engage with, if that's, inability to complete tasks at work, if it's school related, if it's family responsibilities, if it's just lower mood, lower energy, and that I'm gonna be the one to hold that concern right now, and I'm gonna continue to check in on how that's feeling. And we can only meet someone as far as they're willing to kind of meet themselves and meet us in the room. And so I try to create a space as much as I can about that kind of from that place of like curiosity and empathy of like, how is this working for you and how is this not? So really engaging in a lot of motivational interviewing and kind of creating that ambivalence. I think there can be a lot of shame and secrecy around eating behavior, in part to protect the eating disorder, and not wanting it to be found out can be a very I'll sometimes talk with individuals about really like externalizing the eating disorder is almost this like relationship that you're in. It can be a very seductive relationship and very toxic. And so there can be a lot of shame and secrecy around letting someone else in on what the details of that relationship looks like and how that's been impacting a person's behaviors or decisions for themselves kind of throughout the day. And that my goal, right, is to create a place where stress and dysfunction kind of thrive in that shame and secrecy. And so, what would it be like to create a space where for 45, 50 minutes a week, you can be honest about your internal lived experiences as well as your external lived experiences? And I just want to like preface by saying that um, that doesn't solve things immediately in one session, but it can definitely be a challenge when someone is not either aware of what to report or what might be problematic or not wanting or not seeing it as a concern. Um, I think in creating the tracking behaviors, I can definitely resonate with that concern. I will often kind of, depending on what individual is giving me, um, that then kind of informs my next question. So if someone is coming in and is sharing, that they feel like they're eating, 3 times a day, couple snacks, but they try, like, there's some maybe guilt or shame around certain things that they're eating. I'll lean more into just exploring kind of, well, tell me more about that. Do you feel like you have some food rules that you feel like you have to follow? Um, and I may not specifically ask kind of that tracking behavior. Really, trying to get a sense of what the client is experiencing. There can be times where if I'm asking certain questions, if it is like food rules, someone might actually then just share that they've used FitnessPal or Noom in the past. And I'll ask, like, is that something that you're still using, or what was that experience like when you were using it? Did you find that to be helpful, unhelpful, harmful? If there's concern about weight, like if there's a need for weight restoration, um, I I don't have a scale in my office, and I'm really lucky to work in kind of a interdisciplinary setting where an individual might be meeting with a dietitian twice a month where they'll get blind weighed. So I'll have a sense of, is the work that we're doing helping them kind of weight restore, or are they kind of presenting something different in session? I also will talk to individuals about you don't have to get weighed at the doctor's office. It's okay to request a blind weight. Again, which I like, there's other health vital signs that are better indicators. So there are times where I will get a release sign for like someone's primary care or like an urgent care visit where that's shared with me. But there's also lots of times where if weight restoration isn't the primary concern for treatment, I won't ask for weight. I more am assessing like that, how that person is feeling in their body, and kind of managing distress tolerance if their body weight, shape, or size has changed as a result of kind of engaged in more healthier, and by healthier, I don't mean diet culture, but just more variety, more flexibility around food. I'll often share that if someone's weight changes as a result of um, eating like a healthier, more flexible, not following rigid food rules, enjoying kind of social settings more, often your body weight probably like needed to change, and that's okay. And I recognize that that might not feel okay for the individual, but just naming that in some ways not being hyper focused on weight. Yeah, I think there's definitely a balance between getting like a clear assessment of behavior while like also recognizing that it's not like eating disorders are not just about kind of the eating or body image, that is a symptom and how that might be presenting kind of externally, right? And internally, there's a lot of distress, and that there's often kind of comorbidity with, if that's trauma, if that's substance use, if that's kind of just internalized messages around what is worthy or expected or desired from other important people in their life, thinking about kind of the impact of either positive or negative impact that coaches can have, just from the setting that I'm currently working in. And also, like, coming back to, I once had a supervisor in grad school name that, the first session, the goal is to kind of establish relationship and assess risk. And, if you don't gather all the information that you want, that these are conversations that don't necessarily have to happen in that first session. And I will always ask about purging in the first session, because for me, that's a way of assessing kind of that health and medical risk. So like a question that I would ask, like kind of as part of that risk assessment. Recognizing that kind of today's training was primarily focused on kind of that assessment piece, and that we'll just briefly cover kind of some treatment considerations. But as you think about kind of effective treatment planning recommendations, wanting to take into consideration the severity of one's behavior and kind of impact on one's kind of quality of life and health and safety. And so the duration and course, or if someone has had a history of treatment, either voluntary or involuntary, if someone's previously been hospitalized for medical stabilization, they might not be appropriate for like immediate outpatient. Kind of taking into effect kind of either the cognitive or physical deterioration or functioning that may indicate a need for a higher level of care. Another handout that will be sent is kind of just the levels of care guideline, which is a really helpful kind of things to consider if someone is appropriate kind of for outpatient, IOP, or needing more of that like kind of medical stabilization. I've worked with individuals on outpatient before who have come from like a higher level of care or have a history of engaging in treatment kind of at different levels, but have motivation or have not yet tried outpatient and want to see what they can do kind of at an outpatient level before exploring if kind of at this point in their illness, if they need a higher level of care. So I think really assessing one's motivation for treatment, which also I think gets at like that person, like a level of insight and how much this might be interfering, as well as also then looking at environmental support. It can be really hard to engage in treatment isolated around a presenting concern that kind of from a biological, physiological standpoint, we need to engage in eating multiple times a day. And so for someone who has difficulty with eating, if that's restricting, binging, purging, that's really hard. And so also getting kind of a picture of who like is in this person's support. Would their engagement in treatment be supported, or would that be is that not considered a serious enough concern? Would their engagement in treatment cause disruption in their household? And how can we increase support if someone is, wanting to engage kind of at that outpatient level? I think the ideal outpatient team is interdisciplinary, just recognizing the impact of there's medical consequences for kind of long-term engagement in restricting, binging, purging. And so ideally, having a mental health provider who has some training and specialty in this area, or who knows just like, the use of supervision and referral. I think it's really important and can be very helpful. And I recognize that this can be a limited resource to have a dietitian who is trained in the treatment of eating disorders. I'm just thinking, I recently had a family member go through open heart surgery as a part of that kind of follow-up care and treatment, referred to a dietitian. was told, kind of for that presenting concern, to avoid salt and butter. And that is not a recommendation that I would want someone who is engaging with eating disorder treatment to receive. And just recognizing that kind of there's continued kind of specialized training for dietitians. And so just being aware of connecting to someone who has that training. There are some, like in recent years, like on online platforms, some providers who have that training. And so I've had individuals connect with both, it's a platform called Nourish with their insurance to connect with a dietitian that has that training, as well as I have not had a client connect, but have heard positive things about dietitians with that training on an online platform called Fay, Fay. So even if there's not a provider in the community, that those could be potentially a resource for somebody. Again, kind of getting at the interdisciplinary piece, I think it's really important to have an individual with any level of disordered eating history or concern to have an initial physical assessment and comprehensive blood work to help determine treatment plan and level of care. The other thing I'll just name is that sometimes someone can be engaged in pretty severe behavior and nothing will show up on the blood work. So there are times where I have found that lab work can be helpful evidence to get buy-in. And there have been times where I am like just surprised that I don't have, there's no evidence that helps with buy-in. So I'll just name that. Sometimes things don't show up on blood work, even though you think they might. And I'll just name that our bodies work with individuals where this might happen. Our bodies work really hard to function and keep us alive. And so there's often a very slippery slope where things might be fine until they're not. So just wanting to name that. If it's needed, so like often comorbid with anxiety, depression, or other mental health concerns, I think having a psychiatrist as part of that, again, ideal treatment team is really helpful. If that person is already connected to one, I think it's, again, really important to consult and collaborate to make sure that, again, like with any kind of consultation with different providers, making sure you're on the same page, but also I think this can be a presenting concern where splitting of the providers can be common, in part because of the desire to kind of continue to engage in behavior and kind of keep things secret, if that's out of shame, of not wanting to disappoint one provider or just wanting to kind of continue to engage, but report something different to a different provider. And so getting a picture of kind of how that person is presenting kind of for their appointments. Also, if you're the kind of provider who's done the assessment and is aware of the eating concerns, it may be that that psychiatrist has not assessed. That's not uncommon. And so being able to share if there are eating concerns, or even like from a depressive or kind of anxious episode, weight loss, just recognizing that that can reduce medication effectiveness. And so, potentially having to change kind of dosage or medication. There has also been research where certain medications have been found to be pretty effective in decreasing urges to binge and purge. And so for bulimia nervosa, it's not uncommon for buspirone or fluoxetine or Prozac to be prescribed to help decrease some of those urges to engage in the behavior. And then recently, Vyvanse, which is primarily used to treat ADHD, was just approved to treat binge eating disorder. And so collaborating with the medical provider psychiatrist can be really helpful. And again, just kind of offering the most comprehensive care. And I'll just kind of briefly go over this. Really consist, right, of determining need and priority for medical stabilization, and then how to balance kind of that physical health piece while addressing kind of the emotional mental health concerns, or as someone mentioned on an earlier slide, kind of getting to the cause piece. If someone is really kind of engaged in severe eating disorder behavior or kind of compulsive exercise, thinking about kind of Maslow's hierarchy of need, that initial goal is going to be really regulating that eating, so that someone can actually then even fully cognitively and emotionally engage in therapy. So increasing kind of function kind of from the ground up to be able to move towards that more emotion relational focus. If someone needs to gain weight, and it's often referred to as weight restoration. And the other thing I'll just name is that it's not uncommon, given family messages, societal messages, for someone to have like their own goal weight or ideal weight for themselves, when the reality is someone's expected body weight or set point is going to be determined by their own personal history. So this is thinking about like from their pediatrician's office, which isn't always available, growth chart, and genetics and not BMI. That BMI is a really useless physics equation that doesn't give any picture of someone's health. And that I think really, I know I mentioned this before, but recognizing that for any individual that's coming in engaged in disordered eating behavior or has a clinical eating disorder diagnosis, that behavior has helped them in some way. If that's to avoid painful feelings, if that's to establish a sense of safety, if that's just a way of coping with whatever is going on, a sense of a desire for a false sense of control, if other things are just not, there's a lot of things that are just not within our control. And it can also be a form of engaging in non-suicidal self-injurious behavior. And so I, try to come in with the kind of perspective of compassion and curiosity and acknowledging and honoring that this has served you in some way and it's no longer serving you, to then start having a conversation about realistic shifts in behavior. Because you can imagine, right, like even just thinking about like maybe a toddler with a security blanket, if you just take their security blanket away, there's probably going to be a tantrum. They're going to be very upset. That is their security blanket. And so in lots of ways, I kind of see engagement in eating disorder behavior that has been or served in some ways as someone's security blanket. If that's reinforced, kind of internalized messages, and before ripping it away or asking them to not engage, really exploring that, honoring that, and then collaboratively kind of with the individual, what is something that we can experiment with that is more recovery focused or less harmful, kind of that harm reduction model. And so I recognize our time. Want to kind of just briefly go over different higher level of cares and then open it up for questions. And so just recognizing that sometimes people need more support. And so intensive outpatient, since COVID, there's a variety of those that are offered virtually, but that's typically offered 3 to 5 nights per week. That allows an individual to continue to work. And that usually includes like evening meal support and group. PHP is typically 5 to 7 days. That's going to be more intensive, typically 10 to 12 hours. Full meal support, group and individual therapy, and they either return home or stay in long-term housing kind of around the facility. I worked at a partial hospitalization program kind of in grad school. The residential is going to be, again, just like increasing kind of that support. The individual is not going to leave the facility. And then hospital is typically utilized for short-term medical stabilization. For then the individual typically will step down to residential or PHP to continue to engage until the goal is then establishing kind of that outpatient team. So these are some selected references. I know that I mentioned a couple other books, so I'll be happy to kind of send that to Michelle for you all to have as well. Just really want to thank you for your engagement and sharing as you did kind of through the Mentimeter polls and chat. This is my contact information. If you have questions, concerns. I'm happy to have further conversation.